Hi, everyone, and welcome to Age Better, where each week we take a deep dive into all the ways we can feel better, look better, live better, and age better. I'm your host, Barbara Hannah Grufferman. Today, we're talking about one thing and one thing only, statins. We all have questions about statins, especially because statins have become a cornerstone in the management of cholesterol, a key player in our overall heart health, and the number one most prescribed medication in the United States. But the question that often lingers is this: who should actually be taking statins? This is not just a question of medication, but a broader discussion about aging better. Managing cholesterol is a critical part of preventing heart disease, which is the leading cause of death worldwide. Understanding the role of statins can be a game changer in our journey to age better. So to help us navigate this complex topic and to answer some of the questions that you all sent in to me, yay and thank you, I invited Dr. Melissa Tracy, a cardiologist from Rush University Medical Center in Chicago, who is also the medical director of the Cardiac Rehabilitation Program, to give us a masterclass on statins. But wait, there's more. Dr. Tracy will also take a deep dive into the most important diagnostic tests women in midlife should be getting to make sure your heart health is exactly where it should be. So whether you're on statins right now or are thinking about them, this episode is definitely for you. This masterclass will give you the knowledge and tools you need to make the decision that's right for you. So pop in your earbuds, maybe take a little heart-healthy walk while you listen, and then when you're done, share it with the other midlife women in your life so they can benefit from this masterclass on statins too. Stay tuned. Hello, everyone, and welcome back to Age Better Show. I'm your host, Barbara Hannah Grufferman, and today we are talking about one thing and one thing only, statins, what they are, what they do, and should you be on one? So joining me today to talk about all of this and more is Dr. Melissa Tracy from the Rush Medical Center in Chicago. And I believe that you're calling in from Chicago, Dr. Tracy, if I'm not mistaken.
I am.
Welcome to Age Better.
Thank you for having me.
A lot of people have questions about statins. So let's just start with this. What is a statin? What does it do? And why is it so important for our overall heart health?
So our liver produces the cholesterol. The statins, and there's now another form of statins, but the statins work in the liver to help reduce the production of cholesterol and to reduce the absorption of cholesterol. So again, cholesterol is made in the liver. We all make it, but some of us make it in an abundance and some of us make normal amounts, but it becomes sticky and can stick to our arteries. So the statins help reduce the production of cholesterol in our liver and reduce the absorption of cholesterol in our gut.
How do they help in preventing cardiovascular disease, which is a really big concern, really for everybody of all ages, of course, as we know, but especially for women in midlife? This becomes even more important. So how do they help?
So by reducing the production of cholesterol in the liver, so one, we're reducing the amount of cholesterol, total cholesterol, bad cholesterol, the LDL cholesterol. But the statins, which is really important to understand, is that they also have an anti-inflammatory component. So by reducing the total cholesterol, reducing the LDL, the bad cholesterol, that is the oxidizer. When that LDL is circulating in our arteries, our coronary arteries, our cerebral arteries, our lower extremity arteries, it's irritating the vessel wall because it's an oxidizer. But the anti-inflammatory component is really important because we know, especially with stroke and heart attack, there's an inflammatory component to when you have a heart attack or stroke. So when we put patients on a high-dose statin after a stroke or after a heart attack, it is, yes, to lower cholesterol, but we're not going to be able to do that expeditiously overnight. It's also to reduce the inflammatory component that is occurring with those acute events. With women, as they go through menopause, those protective hormones, especially the estrogen, they fall. And what happens as we go through menopause, our blood pressure goes up, cholesterol goes up, our weight goes up, and there's a multitude of other symptoms that women can have. So women will say, my cholesterol has never been a problem. But I'm maturing in age and I'm either peri or postmenopausal. So the statins are really important for women, especially as they continue to get out of the menstrual cycle and into the peri and postmenopausal. Once they're postmenopausal for about 10 years, their cardiovascular risk is now equating that of a man. And if I could just add, women are great advocates for everybody around them.
Yes.
They have to become their own self-advocate. It's really important to treat your body as a gift, as a gift to yourself, as a gift to everybody else. So you can continue to be a self-advocate for everyone else, but don't forget yourself.
Right. Wonderful, wise words. Thank you. We're moving into a very crucial question, which a lot of people have. Who should be taking statins? Can you tell us about the different groups that are really like good candidates for statins?
So I break this down into primary prevention and secondary prevention. Secondary prevention is pretty straightforward. Those are patients who have already had a cardiovascular or cerebrovascular event, a heart attack, a stroke. Those are patients who, if there are no contraindications, really must be on a statin, and be on a statin that really optimizes the reduction in that cardiovascular risk. So just putting a patient on a statin and then never checking the cholesterol again is not the way we do it. Starting a patient on high dose statin and never checking the cholesterol again is not how we should do it. So there are optimal numbers that we look for. So once we put a patient on a statin, we should then be tracking how is the patient responding and making sure that if they're not responding on the dose that we initiated, that we discuss with them the next stage, and that would be going up on a dose. So secondary prevention, like I said, is pretty straightforward. Primary prevention are for those patients who have not had a cardiovascular event. However, they may have other cardiovascular risk factors. They maybe have obesity, diabetes, hypertension, smoker, a woman who's menopausal or perimenopausal. And then it's really important to understand family history. So when we look at risk factors, there are modifiable risk factors and there are non-modifiable risk factors. The non-modifiable risk factors include getting older. I like to say getting more mature, going through hormonal changes with perimenopause and menopause, and our family history. We cannot change those factors, as well as our gender. Those are set. But we do have a lot of modifiable risk factors, and that's our weight, our sugars, our cholesterol, our blood pressure, and whether or not we elect to smoke or not. So looking at the primary prevention, if your cardiovascular risks portend a higher risk and your cholesterol is elevated, so total cholesterol greater than 250 and an LDL greater than 130, 160, those are markers that I better start thinking about not only a statin, but absolutely coupling this with a healthier lifestyle.
Right, lifestyle factor. You did mention as one of the risk factors is being older or mature, as you put it, but also being postmenopausal. So when estrogen levels drop or fluctuate and then drop completely, and then you're postmenopausal, how big a risk factor is that?
So again, it's a gradual process. One is if a woman has had a hysterectomy, hopefully there was not the need to take away her ovaries. If a woman has had a hysterectomy and they've taken her uterus and her ovaries, she goes into almost immediate menopause,
right,
because she doesn't have that weaning off process. So that's really unfortunate. There are situations where a woman has to have her ovaries removed in the process of also having her uterus removed. So that is an immediate risk factor because her hormones are gone.
Right.
The process of a perimenopause going to menopause does typically take about 10 years. And so through that period of time where a woman is becoming perimenopausal, she really needs to be looking at, am I eating properly? Am I exercising enough? Am I sleeping enough? Am I dealing with my own mental health? And making sure that it's not 10 years down the road where all of a sudden now she does have elevated cholesterol, elevated coronary calcium, or her BMI has now exceeded from normal to overweight to obesity. It is a process for women. And during that process, they really need to make sure they're taking really good care of themselves.
Thank you for that advice as well. What are some of the factors that patients should really consider in partnership with their trusted healthcare provider, I always like to say, in deciding whether or not to take a statin? Is there some go, no go point? I mean, you mentioned some factors. You mentioned, of course, cholesterol numbers. Anything else that they should be considering?
So again, looking at the patient as a whole, one of the things I have to urge patients is smoking. There's nothing good about smoking from a health perspective. It's not sexy. It's not pretty. So smoking is one of those modifiable risk factors that I would really urge our listeners to start working on if they're smokers. But this also includes the vapes that people are doing and the juuling that people are doing, because not only are they getting the nicotine from those products, but they're also getting all those oils. It's all heated up. And we don't know exactly what the intensity is of that on our lungs, our heart, and our brain. So smoking is a no-go. So looking at the patient as a whole, what are their risk factors? And again, if we're going to focus on primary prevention, do they have a lot of risk factors? And which one of those are modifiable? Which one of those are non-modifiable? Every visit, I'm talking to my patient about their pulse, their blood pressure, their weight. We discuss how their weight has fluctuated from one visit to another. And I also talk a lot about sleep, because sleep is another one of those fourth vital signs that we need to make sure that patients are getting enough sleep. So if their risk factors are mounting, because we can't do anything about our aging process.
Or being postmenopausal. Those are two things that you cannot change.
You cannot change.
At the moment.
Yes. And I don't foresee that we're going to be able to change that. But if our risk factors are mounting, we have to look at the cholesterol. We have to look at our weight. What are we taking in? What are we expending? So if we want to keep our weight at a healthy level or lose weight, we have to expend more energy than we're taking in. The average American is not getting in the minimal 150 minutes of moderate intense activity per week. They're just not.
Absolutely not. And I can't tell you how many episodes I've done over the years, nagging with love in my heart, as I always say, to keep moving throughout the day, not just being a weekend warrior, as many people do, because you're so busy during the week, but throughout the day.
Absolutely. And then you look at the cholesterol and you look at the total cholesterol, you look at the triglycerides, you look at the HDL, which is our protective cholesterol, and you look at the LDL, which is the bad cholesterol. And then you can couple that with a coronary calcium score. It's a really easy study. So I use the coronary calcium score quite a bit. One, to motivate patients to stop smoking if they're smoking, motivate them to do more about their weight or their cholesterol. So coronary calcium score is extremely helpful.
Please go into a little more detail on the calcium score test, because I did have a guest on the show last year who told me about a very dear friend of hers, a runner like she is, who died suddenly of a massive heart attack. And it was only then they discovered that she did have plaque buildup. Had she had that simple, non-invasive, inexpensive, quick test that you just referenced, her life probably could have been saved. So I immediately got a calcium score test. Here's the thing, Dr. Tracy, no one, and I have very good doctors and I have access to some really incredible people because of what I do. No one ever said to me, hey, you should go and get your postmenopausal. You should go and get a calcium score test. So I have been talking about this a lot. And last month during February's, Heart Health Awareness Month, I talked about it a lot, did little videos about it. So if you could just please explain how quick and easy and inexpensive it is so people are encouraged to do it. And a little bit about the numbers. Like, of course, the ideal is 0, right?
Yes.
But what, in your opinion, if you see, and I guess it has other factors, of course, to take into consideration, but if one of your patients who is postmenopausal has a certain number, at what point will you say, I think I'm going to put you on a statin now? Can you please share?
So coronary calcium score is a great screening test. It's a screening test because it gives us a number. It gives us an idea of where that calcified cholesterol is in the coronaries, but it doesn't tell us if the amount of calcium that is in your coronary is what we call hemodynamically significant, meaning that it's obstructing the coronary from behaving appropriately when you're asking the heart to do more. So it's a very easy test. It's minutes. There's no IV necessary. There's no contrast necessary. Yes, there's ionizing radiation, which is equivalent to about 2 to 3 x-rays. That's it.
That's it.
That's it. We get ionizing radiation when we fly. So it's not as if we're blasted with radiation when we're getting the coronary calcium score. So really quick, easy test. I think the reason why it was not as much used in the past is I think people didn't know what to do with the numbers.
Interesting.
And now we know the significance of these numbers, and we know that there's a way of stabilizing these numbers. So yes, the ideal score is 0. That's the ideal. And then it goes up in increments. So we go 0 to 99, 100 to 199, 200, and then beyond. I actually have patients with calcium scores in the thousands.
Wow.
Yes, and they have a lot of risk factors.
Yeah.
Those are patients who tend to be diabetics, who have end-stage renal disease, who are possibly on dialysis. So that number can go into the thousands. My highest coronary calcium score that I may have had was, I want to say, 6,800 for one of my patients.
Holy moly.
So yeah, holy moly is right. When I look at this score, so again, quick, easy study. A lot of hospitals, you can self-refer yourself. You don't even need a prescription from a doctor. Now, you do need a doctor to help you interpret that number. You should have a healthcare provider who helps you interpret it, helps you understand what does it mean and what can I do about this calcium score. And it's not calcium that we're measuring. It's cholesterol that has said, oh, I want to stick to your coronary arteries. And it sticks to the wall of the coronary arteries. And in the process of sticking there, calcifies, gets hard. So the coronary calcium score tells us cholesterol, which is already laid down into your coronaries and has calcified. The one caveat that I like to, though, also say is it doesn't tell us if there's soft cholesterol there. So if you have a low calcium score or a 0 calcium score, but you're not eating well, you're overweight, or your lipids are abnormal, that doesn't mean, party time, I don't have to do anything. It tells us that this is great. None of that cholesterol has calcified, stuck and calcified yet. Doesn't mean that you don't still need to take really good care of yourself. As that coronary calcium score rises, it absolutely increases your risk from low cardiovascular risk, that's below 100, to moderate to high. I will, even if it's in double digits, I still am pretty aggressive. So I am a pretty aggressive healthcare provider, cardiologist, because if you are 30, 40, 50, 60, and you already have a positive coronary calcium score, positive in the sense that it's not zero,
Right.
then we have to look at where can we modify your risk. So I'm really big into shared decision making. I talk to my patients. This is what we can do. Every one of my patients, if I'm going to use a statin or not, will have a pretty in-depth discussion by me about healthy diet, healthy exercise, healthy weight. I've been an athlete my entire life. I've had injuries, so I've known how to recover from injuries. How do you fall down and get yourself back up? So I will really discuss with my patients exercise. I try to find out what it is that they enjoy doing or what it is that makes them so negative about exercise. I use exercise like a shower. I say, do you shower daily? Maybe you shower, maybe not every day on the weekends because you want to just chill, but you like to shower. My patients will look at me a little strange and they'll say yes. And I go, makes you feel good. I said, if you don't shower, you feel scuzzy. I said, well, if you don't exercise, you should feel scuzzy. You should feel dirty. You should feel not right. So I said, you've got to start incorporating exercise into your life, embracing exercise. I will then also look at their diet and we will go over. I said, okay, tell me what a typical breakfast, lunch, dinner, snacks. Patients do a 3-day dietary log. And I'll tell them, write every single morsel of food that you put in your mouth. Don't review it. I don't want you to review it until the 3 days are over. But every single thing you eat or drink for 3 days, you write down. And you will be amazed things that you don't realize that you're sneaking in.
Right.
When you want to nosh on something in between a meal or you're cooking dinner, you need to write down all of those things. And then I want them to keep a record of what it is that they're doing with their day. How are they navigating their day? Are they sitting? Are they using stairs rather than the elevator? Are they using stairs rather than an escalator? So I'll go through all that. But if their coronary calcium score starts to rise, we have a discussion about a statin. And we have a discussion about where are we going with that statin? Is this an indefinite time course that we're going to be on a statin, or is this a limited time that we're going to be on a statin? All those things have to be taken into consideration.
You know, what you just brought up now is one of the questions that an Age Better listener did send in to us. I had invited them to send in their questions for you, which we are going to get to in a minute after I finish going through my own questions. But that is one of them. Like, is this a forever thing, or can I at some point get off of a statin? So we will get to that question in a minute. So at what age do people generally start?
I think for the most part, we probably start them too late because one, we don't want to add more medications to a patient's list because we know how much patients, for the most part, don't like to take medications. Patients are also having that aha moments, more 40s, 50s, when they start hearing about maybe a friend or a family member who has had a cardiovascular or cerebrovascular event. So it really varies on what the trigger is. Was it something that happened to you or someone in your bubble that says, oh, I need to look into this? Was it an astute healthcare provider who said, you know, you haven't had your annual cholesterol. Let's do your annual cholesterol. I have patients as young as in their 20s on statins, and I have patients as old as in their 80s on statin. But I would say for the most part, patients have those aha moments or have those relationships with a healthcare provider, probably more midlife. And the reason why I say that sometimes I think we're starting them too late is if you look at the bell-shaped curve of an elevated LDL and you see where we started a patient on a statin, that whole area under the curve is when their vessels have been under that oxidizing stress of the LDL. So the LDL has been irritating those vessels for years, and then we're trying to play catch up.
Right.
So I have one patient, like I said, she's in college. She's an athlete. She came to see me. She's extremely healthy. She plays Division I soccer, but her uncle, who's her mom's brother, had a stroke at a young age. He's a physician, and her mom has really high cholesterol. They are both on statins. Her mom's on a statin, and her uncle, the mother's brother, is on a statin. Her cholesterol was pretty high. I didn't put this patient through a coronary calcium score. I had shared decision making with her. I talked to her about this area under the curve with the LDL and said, you're doing everything right. You're exercising, you're not overweight, you're eating well, but you have a mom who has high cholesterol, and you have an uncle who not only has high cholesterol, but had a stroke. And the stroke was in his 40s. We have her on a statin.
Oh, yeah.
And she and her mom and her uncle were thrilled that we had this discussion. And she made the decision, but her mom and her uncle were definitely involved. And when I was at the American College of Cardiology meeting a year or two ago, there was a pediatric cardiologist who was talking about statins and that we're not doing enough in our children to get them on statins. So I went up to the podium or up to the microphone and asked a question specifically about this patient. And she was thrilled that I had started this young lady on a statin because her risk is only going to increase as she matures in age, as her hormones change. And by then, is it too late? And will I not have been able to aid her in her preventing having a stroke? So I have patients, I don't take care of patients younger than 18. So my patients are 18 and older, but she is probably my youngest patient. I want to say she's probably now 22, 23, but I have patients in their 80s on statins. As patients do mature in age, we do have a discussion about, do I have to continue this? Do I need to start this? Because it is a risk versus benefit ratio. And as we mature in age, we're only here, hopefully for an extended time, but it's a finite time. And so if we have a risk versus benefit ratio and a patient has either not been on a statin, but comes to me late in life, or has been on a statin and just is really tired of taking medications, or I'm having more aches and pains. Maybe it's the statin, maybe it's not. Again, shared decision making about what is the benefit of starting a statin later in age and what is the risk of starting a statin later in age.
Right. I am on a statin now. I did mention before that I finally did have the calcium score test after I had this person as a guest on my show who encouraged me to get the test. And it did show double digits, 14, not high. I'm sure you would agree. And then when you couple that with the fact that I am doing everything right as far as we know, I'm a runner, I do strength training, I eat well, I sleep well, I manage stress, I'm really doing everything good for myself. But my doctor really felt very strongly that even though you're doing all of these things, the fact that it is 14, we're going to put you on a statin. It was a shared decision, as you put it. Absolutely. I thought about it. And then when I did my own research I decided, yes, this is the right thing to do.
I think shared decision making is important because it empowers the patient to educate him or herself, to feel that they've been at the table, that they haven't been just written a prescription or talked to.
Right.
They've been part of that discussion.
Yeah.
I think it is so important. I really appreciate when patients ask me questions. I want them to ask me questions.
Yeah. And part of what I hope that I do with the show and other things that I do is to give the listeners the tools to go in and have those kinds of discussions with their healthcare providers, hopefully.
Absolutely.
Because you have to be your own advocate. You really have to be. I do want to get to those listener questions because they're really so good. But I just wanted to know, what kind of tests and assessments would you have your patients and would you encourage the listeners to get as they're considering a statin?
Definitely liver function tests and your muscle enzyme, your CK.
Your CK.
Yes, your statins can affect the liver and they can result in muscle breakdown. So I check the fasting lipids. I'm still of old school. I like doing the fasting lipids. So you can check the lipids non-fasting, but I'm old school. I like patients, nothing to eat or drink after midnight or 6 to 8 hour fast, come in for your lab. So I check the full lipid panel. I check LFTs, which is typically just the AST and the ALT. Those are liver function tests.
Right.
And then the CK. Once I start them on a statin, I will check all those numbers again in 4 weeks and make sure that I have optimized the cholesterol, typically total cholesterol less than 200, triglycerides less than 150, HDL or good cholesterol as high as possible, LDL less than 70. And we're really advocating 55, 50.
Yes.
We're really pushing that LDL lower.
Yep.
But I will also check the liver function tests to make sure that the liver is not getting irritated by the statin. And I'll also check the muscle enzyme, the CK. That muscle enzyme can fluctuate a bit with activity. It can go up modestly, and that doesn't have to be because of the statin, but I still will check that and see where we are. And then I'll check, depending on if the patient has had no change in their health systems, that everything has remained stable, I'll then check all those numbers again annually. There are some patients who shouldn't be on a statin.
Right. That was my next question. Let's go right to it. Who should not be?
Women who are pregnant or want to become pregnant should not be on a statin. Patients who do have liver abnormalities. And there is a caveat to that, because one of the leading causes, and will probably become the leading cause of liver failure in this country, is fatty liver, non-alcoholic cirrhotic liver. And in those patients, their liver is not functioning properly because it's overloaded with fat. Those patients can have elevated liver function tests, but the statins can actually help those patients. So not every patient with an abnormal liver cannot be on a statin. And again, patients who have fatty liver actually benefit from a statin.
That's interesting. I never heard that before. I did not realize that.
Yes. So if you have fatty liver, and again, that's going to be the leading cause of liver failure in this country because we have such an epidemic of obesity. And then the patients who shouldn't be on it, also there are rare myopathies, inflammation of the muscles, that the patient cannot be on a statin because they're already breaking down their muscle, and you cannot monitor whether or not that CK that is in their bloodstream is coming from their myopathy or from the statin. And I actually have a young man, he has McArdle's disease, and he didn't know he had this. He always knew his muscles fatigued, but he didn't know that he had this. He was in Mexico with his friends. He got pulled out by a wave, and he was struggling. He was drowning. He was essentially drowning. And his friends thought that he was joking. So they just let him struggle. He says, I don't know how I got out, but I got to the sand and I was done. And that's when his friends realized he was not joking. He had this exertional fatigue before. He just would go home, rest. So he goes back to his hotel room and just sleeps for like 2 or 3 days. He cannot get out of bed. His friends take him to emergency room in Mexico. He is an acute renal failure.
Oh my gosh.
With potassium that is cardiotoxic. And the doctors in Mexico say, you need to get back to America. He gets on a plane with toxic levels and gets to the hospital and is emergently dialyzed. He gets a muscle biopsy and finds out that he has this myopathy. And so he's had it for years. He was born with it. He didn't know he had this, but he also has coronary disease. So I have to have him on a different form of cholesterol lowering medication. It's actually one of our injectable cholesterol lowering medications that doesn't affect the muscle enzyme, but improves his cardiovascular risk. So those are the big groups. And then I think you can put age into it, but the age is really a matter of, is the patient got other age-related issues that prohibit them from being on a statin? Or do they just wish to simplify their medications and choose not to? So age is a relative decision maker, but pregnancy, the attempting to get pregnant or pregnant, patients with liver disease, which prohibits the use of a statin, or those patients with myopathies that would prohibit the use of a statin.
Got it. Wow. Thank you for telling us that story. Incredible. I'm happy for him that he has you as his doctor.
Yes. I'm happy that he found
Yeah,
us.
I'm very happy for him. The most common side effects associated with statins, I mean, what I've heard is muscle aches. What else should we know before we move on to our listener questions about the side effects?
So there are statin-related symptoms, and then there are statin-induced myopathies. Those are totally different things.
Very different.
So statin-associated symptoms, SAM, are just symptoms, and they're nonspecific. They can be joint aches, muscle aches, fatigue. Those are the symptoms.
And are those permanent as long as you're on the medication, or does your body get acclimated and they ease out?
Both. Okay. It really depends. So I will tell patients the most common symptoms: muscle aches, joint aches, fatigue. And then I will tell them I have to monitor some tests, your liver and your muscle enzyme, because the statins can irritate the muscle, irritate the liver. It's really challenging to know when patients have symptoms. Are they symptoms truly related to the statin? Are they psychosomatic symptoms? Are they symptoms related to something else? They've had the flu, they did too much working out, they decided to be that weekend warrior, and their symptoms are related to this. So the reason why that's so important is that the benefits of the statin are huge for reducing or improving our cardiovascular mortality and morbidity, that you really don't want to be haphazard and say, oh, stop the statin, because there's a reason you started it. And so the reason to stop it has to really be thought through well. And then the statin-induced myopathies, those are true. That's true myopathies where the muscle is breaking down or can affect the nerves and cause some tingling or numbness. And with those, some of those, if you don't modify the statin, yes, can actually become permanent. So you have to decide, are these symptoms? Are these induced myopathies or neuropathies? And adjust the statin accordingly. So what I will often do is I will stop the statin if the patient is just saying these symptoms are not getting better, or I will cut the statin in half. So I'll modify the dose. And
is a matter of also switching to a different statin? Does that sometimes help also?
Absolutely.
Okay.
Yes. I typically start with more of the efficacious statins. That's the atorvastatin, also goes by Lipitor, or rosuvastatin, which goes by Crestor. Those are our newest statins, and those are the most efficacious statins. So yes, you can reduce those. You can, with the rosuvastatin, because it has a longer half-life, you can try taking it every other day to see if you can gradually get the patients up to a level of the statin which optimizes their cardiovascular risk. But then there are older statins which work: pravastatin, Mevacor, lovastatin. So there are other statins that we can use. There are other agents that we can use. There's an agent called ezetimibe, which lowers LDL. It only lowers LDL. It blocks the receptors in the bowel that would allow LDL to get absorbed. The issue with ezetimibe is it only lowers the LDL, and it doesn't demonstrate the robust improvement in cardiovascular morbidity and mortality that the statins do. So it absolutely has a benefit. It lowers that LDL, lowers that oxidizing agent, but it doesn't improve to the extent a statin. And then there are other agents that we can use, but we sort of have to go through this process because the way insurance navigates and dictates how we do it, it's still with a statin. Try multiple statins, try Zetia. There's a new non-statin statin called bempedoic acid, which requires to become activated in the liver and only works in the liver. So it doesn't affect the muscle.
Interesting.
And it has excellent outcomes to equivalent to the statins. But we do have to still, based on how the system works, we still have to start typically with a statin, try a different statin, try ezetimibe, and then we can consider bempedoic acid. And then there's the injectable agents, the PCSK9 inhibitors. I mean, they're absolutely amazing. And you inject them twice a month. And the outcomes that the injectables have are the way they affect the cholesterol is amazing. That drops the numbers in half, if not greater. But they're an injectable. And so we have to make sure patients are okay with injecting themselves twice a month. It's pretty easy, but the whole notion of having to self-inject yourself can be a little bit queasy for some patients.
Sure.
But we do have to work through a process. And we start with the statins. From the statins, we would go to the LDL receptor blockers, the ezetimibe. And then we can then discuss whether or not we want to add bempedoic acid or PCSK9 inhibitor.
And with regards to injecting oneself, I think a lot of people are getting quite used to this now with Ozempic.
Oh, yes.
and other similar drugs.
The miracle agents.
Absolutely. It is, I mean, this is kind of going off topic for a minute, but I keep seeing more and more studies about what Ozempic can do. Now it can fight kidney progression.
Yes.
It's just an incredible, it's almost like a miracle drug in so many ways.
It is. It is. Our insurance companies, though, are reluctant to cover them. And you have to do a cost versus benefit risk factor ratio. Absolutely. Right. But yeah, that could be a whole nother discussion that we can talk about.
Absolutely.
Yes.
Now, very importantly, I know a lot of people are waiting for this. I want to get to the specific Age Better listener questions that they sent in. Here we go. If statins aren't an option, what alternatives do patients have for managing their cholesterol? And I think you've already answered that earlier, but if there's anything you wanted to add, I mean, you went through, and I will have those in the show notes too, so people can read it as well as listen, get more information about each one. But any other options you want to talk about or no?
So first, we've already said lifestyle.
Yeah.
No doubt that lifestyle is so important. But you would start that the statins are typically the first agents, then the ezetimibe, the bempedoic acid, which is our new non-statin statin, the injectables. Some patients may also need to be on medications to lower their triglycerides specifically because they haven't gotten there with the statin. So there are agents to specifically lower the triglycerides. The two ways to naturally increase your HDL, because you want your HDL as high as possible, exercise is one of the key ways. Absolutely. If you want to increase your HDL, absolutely exercising. There are a lot of patients who will ask me about supplements.
That is the next question. Are there, sorry to interrupt, are there any natural supplements that are as effective as statins? One that was mentioned to me, this is the listener, is CoQ10.
Yeah, coenzyme Q10. So none of the supplements are going to have the equivalent of a statin. There's none that are equivalent. So there are patients who will use, a lot of my patients like the red yeast. Reason I'm not a big advocate for the red yeast is why take a supplement that may have benefits, but you don't know absolutely everything that's in it. So when you're getting a bottle of supplement off of a shelf, that supplement is not regulated to the extent that a prescription medication is. So you have liberties. You could take as much as you want. You can take as little as you want. You can be as non-compliant on it as you like. You can buy the more expensive one. You can buy the lesser one. I don't remember this percentage specifically, but if in the ingredients, the manufacturer has put in items which are less than a certain percentage, they don't have to list that ingredient on the bottle. So you don't know necessarily what all the ingredients are, and they can be quite costly. I have a lot of patients who are just supplement. I am not a supplement advocate.
Nor am I. Vitamin D and a multivitamin. That's it for me.
Yes. And I tell my patients that right off. I said, I'm not going to tell you to stop your supplements, but if you're asking me whether or not you need to take a supplement instead of a medication that I know has the science behind it, you're not going to get potentially the answer that you need.
Okay.
The coenzyme Q10 is to help with the muscle aches. So what I will have some patients do is I'll have them take their coenzyme Q10 about an hour before they take their statins. And some patients have found that it has helped them tolerate the statin. So it's not a supplement or a alternative to a statin. It is an additive that may help you tolerate the statin better.
Oh, that's very interesting. And also timing of a statin. Is it better to take, or does it matter? Take it in the morning, at night, with food, without food?
We typically tell patients to take it at night for two reasons. One, atorvastatin specifically can have interference with citrus juices, especially grapefruit juice. So a lot of people don't have grapefruit juice at night. They have it in the morning. But we also metabolize cholesterol at night. So the thought processing be take the statin at night when our body is more naturally metabolizing the cholesterol. However, if a patient doesn't drink citrusy, specifically grapefruit in the morning, and it really helps with compliance, take it in the morning.
Okay.
Whatever helps with compliance, so long as you're not taking it with grapefruit juice, take it whenever, but stay compliant with it.
Okay, next question. I don't take statins because of side effects, including joint pain. My cholesterol is just a little over the high mark. I guess a little over 200 or whatever. I exercise twice a day. Is this enough to protect my heart?
What's your coronary calcium score?
Exactly.
That's what I'd like to know.
Yeah. So that's what this person needs to find out.
Yeah. If your lipid panel is not normal and you're maturing in age, and let's just add in that you're postmenopausal, so you have three risk factors right there. You have elevated cholesterol, you're maturing in age, and you don't have the protective estrogen. Let's see what your coronary calcium score is.
Okay, next question. Why do some people like me have an intolerance to certain statins? Why?
Well, one, whether or not it's a true side effect or not. So there was a really nice study done with statins. It was a double-blind study looking at what we call nocebo effect, meaning there are side effects to medications. You know about the side effects, so you're going to have the side effects regardless if you have an inherent intolerance or not. And what they did is they had two groups, and one group got a statin, one group got a placebo, and they switched them. Nobody knew what they were on. There was not a difference in the complaints for the muscle aches or joint aches. So there is something called nocebo effect, meaning you're on the drug and thus you believe that you have the symptoms. So it's really, really important to really decipher whether or not those are true symptoms. So some of it is that you just are intolerant. There are people who are intolerant to the components of the statin. There are patients who it is psychosomatic. So I don't really think I have the answer for why there may be a genetic component, but a lot of the complaints with the statins really have to be tweezed out to what is a true symptom or a true statin-induced myopathy, and what is a placebo, nocebo, psychosomatic side effect. And it's really important to figure that out because those risk factors are really, the side effects of the statins are really, really low. But everybody believes that they're going to have these symptoms. And I had a patient the other day who asked me, well, what about this side effect? Or what about that side effect? And I said, fair. So I went through the side effect of this and that side effect. I said, and let me turn this around. What is the side effect of having a heart attack? What is the side effect of having a stroke? And when I said heart attack, he goes, oh, no good.
So no good.
I said, and his stroke, he said, no good. I go, so let's work on this together. And I said, so that we can reduce your risk of having a heart attack or stroke with the minimal amount of side effects. I don't want you to suffer with side effects. So if you develop a side effect, we try to alter the milligram dosage. We try to alter the frequency of the medication. We try a different medication, but it has to be a balance.
That's great. Thank you for that answer. And then is there an age when statins are no longer prescribed?
I hit on that earlier. I think, again, that's really shared decision making. If a patient is in their 80s or 90s and for whatever reason, whether it's that they have another health-related agent that prohibits the use of a statin, if they're on other medications that could interfere with the metabolism of the statin because it's also being metabolized in the liver, or they just want to minimize the medications. I think it's really depends on the individual. Often, and we did hit on this, statins do tend to be indefinite because we are maturing in age, we are losing our hormones, we do possibly have that family history, or we've had that secondary event where we've already had the heart attack or the stroke. Statins are pretty definite. They're not going away. So taking a statin is not like putting a Band-Aid on a wound, and then you give the wound time to heal and you can remove the Band-Aid. Those risk factors are still there. And so there's very few reasons I can think off the top of my head that I would start a statin for a short duration of time. I have had statins who have had bariatric surgery that they've lost 100, 150 pounds. I've gotten people off statins. That's the extreme.
The next question is, if your cholesterol is at a good level after being on statins for many years or for a while, how do you know if you need to stay on them? Things might have changed. As you pointed out, our bodies are evolving and you might no longer need them. How can this be assessed? Or should we just stay on them for the rest of our lives? That was the question.
I think, again, there's not many reasons I can think of outside of extreme lifestyle modification. So you've gone from couch potato to marathon runner to fast food addict to a healthier diet and have lost an excessive amount of weight, and your other cardiovascular risk factors are optimal. Example, like I said, if you've had bariatric surgery and you've lost 150 pounds, if there's really the thought that you want to be off a statin, really the only way to know if you should be off a statin is by stopping it. But I would not do that on your own. I would discuss that with your healthcare provider, see if they agreed that there's a time period that you can be off of it, and to reassess. That's really more so for primary prevention. For the secondary prevention, you've already had an event. We don't want you to have another or a third. So I think for the secondary prevention, for patients who have a stent, patients who have had a heart attack, patients who have had bypass surgery, patients who have had a stroke, you've had that aha moment. We want to keep it, I'm still here moment.
That's how I feel. I mean, I haven't had any of those happen to me, thank God, knock on wood.
Yes.
I am still primary prevention.
Yes.
But I personally can't anticipate getting off of a statin because I'm already doing everything right for myself.
Right.
And here I am on a statin. So in my mind, I've already acclimated myself to the idea that this is going to be a lifelong thing. And that's okay. Again, as I said earlier, I'm happy that we have such a pill as a statin. So this is really, I wonder if you have any opinion on this. People say, avoid getting on statins at all costs. I myself have seen on social media, on TikTok and Instagram, people, supposedly doctors, saying, never get on a statin, stay away from statins, they're overly prescribed, and so on and so forth. Why? Why all the negatives, in your opinion?
I don't know.
You just don't know.
I don't know. As I said, I think that we start them often too late. I think that the benefit of the statins greatly, greatly outweigh the risk and the side effects. So I don't know. I can tell you this. I also run our cardiac rehab program, and cardiac rehab is for secondary prevention. And nationally, it is so underutilized. And I cannot answer why, whether it's the lack of referral, the lack of the enthusiastic referral, the lack of knowledge about cardiac rehab, the lack of self-motivation of patients. But we have so many patients who are not heeding the benefits of cardiac rehab that I'm perplexed. So I'm perplexed.
So am I.
I'm perplexed. Yes. So I don't have an answer for that.
I throw that into the same category as people who don't believe in vaccines. I mean, to me, just put it in the same box. We do have more questions from our listeners, but we won't be able to get to them at this time. But Dr. Tracy, please come back. Just say yes, you'll come back and we'll do part 2 of this, because
we could do part 2.
We have too much to talk about. But before we let you go, and you have to see your patients, can you just maybe give us a few takeaways that you really want this audience to remember from our conversation today?
Exercise is a gift you give yourself. Give yourself that gift. Think about all of the science that has gone in the discovery of many of our medications. Listen to the science and not the gimmicks from Dr. Google. And then, ladies, you don't have to suffer through menopause. Please talk to your doctor about getting hormone replacement therapy so that you don't have to suffer.
Thank you so much for all of that. Thank you for your time. I am so grateful. This was a true masterclass in statins, Dr. Tracy. I know you'll be back. Thank you so much.
Thank you so much for having me.
Thanks for tuning in, everyone. If you enjoyed this episode of Age Better Podcast, please do a few things. First, share it with all your friends and family. Then, subscribe to Age Better wherever you listen to podcasts, including YouTube, so you never miss a single episode. Finally, if you have ideas for topics you want me to cover in a future episode of Age Better, send an email to agebetterpodcast@gmail.com or reach out to me on social media. Until next time, remember this: we can't control getting older, but we can control how we do it. Talk to you soon. Age Better Podcast is a proud member of the Sound Advice Network. Sound Advice, women's voices amplified.